Well, hello and welcome back. This is part 2 of the heart video, and in this video we're going to talk about the cardiac conducting system, we're going to talk about EKGs, heart physiology, and just wrap up why exercise is good for your heart. So the heart cardiac conducting system is made of special cardiac muscle fibers called autoarrhythmic fibers. These autoarrhythmic fibers have the ability to generate their own depolarizations. And that's very special. Very few cells in the human body can actually do that. So these cells are self-excitable. They can generate action potentials, which can be the signal to contract heart muscle tissue. So part of the cardiac conducting system begins with what we call the sinoatrial node or SA node. This is the pacemaker of the heart. It's located in the upper right atrium, and these specialized cardiac muscle cells generate electrical signals that will tell the atria to contract. This wave of electrical activity will spread through the cardiac muscle cells because there's gap junctions that allow them to send signals from cell to cell to cell. Next part of the electrical conducting system, or the cardiac conducting system, is the atrioventricular node or AV node. These fibers are actually small, and they're slow, and they're located in the septum that separates the atrial tissue from the ventricle tissue. It transmits signal to the next part of the cardiac conducting system called the bundle of His. So the AV bundle or bundle of His will actually split, and it'll become the bundle branches, and these are large fast fibers that are located in the septum, which is the muscle tissue that divides the right ventricle from the left ventricle, and these eventually will transmit the signal to Purkinje fibers. If I back up just a little bit and just draw that box diagram that we are familiar with that we did earlier on. So the SA node is going to be located up here in the right atrium, and it's going to send a signal out that will spread through the atrial muscle tissue, okay, in that figure 8 pattern of the way the muscle tissue grows. Eventually the signal will arrive at the AV node. That will then send a signal to the bundle of His, which will bifurcate and then send the signals to the Purkinje fibers so that the ventricles can contract. So the atria contract first, and then the signal slows down and is sent to the ventricles, and then the apex of the ventricles contract, and then the wave of electrical activity or a spread of contraction goes upwards. So the blood can be ejected out of the heart in the correct direction. And this is artist rendition showing you the SA node up in the upper right hand corner. The wave of electrical activity or the signaling is spread across the atria. Atria contract. The AV node is going to slow the signal down. The bundle of His will bifurcate into the bundle branches so that the signal can be sent to the left side of the heart and the right side of the heart. It goes through the septum, which is the muscle tissue separating the left ventricle from the right ventricle. Purkinje fibers then pick up the signal and send it to all the heart muscle tissue, so we get a full contraction of the bottom part of the heart. So there are things that influence the conducting system. Of course, you have to have the autoarrhythmic fibers in the SA node to, as the natural pacemaker of the heart. They will initiate the action potentials, but there are things that can modify the initial pacemaker of the heart. So there are signals from the nervous system. Parasympathetic nervous system and sympathetic nervous system will stimulate the heart to slow down or speed up. And then there are hormones circulating in the bloodstream like epinephrine, which can modify the heart rate and also the force of contraction. Typically these don't set the normal fundamental rhythm though. That's made by the pacemaker of the heart. Well, if for some reason you have damage to your pacemaker, we can put one in. We can insert it underneath the skin, thread the little wires that will send signals to the muscle tissue through branches of the superior vena cava. We can then thread those into the heart muscle, and then when you need a signal, there is a battery in there that will send a little electrical shock to get the heart back into the right rhythm. So bradycardia is where you have a slow heart rate. Tachycardia is where we have a fast heart rate. So sometimes if it's too fast or too slow, we can send a signal and get it back into the right rhythm. All right, we'll move on now and shift gears and talk about the electrocardiogram. This is also known as an EKG or an ECG. An EKG is a recording of the electrical changes that accompany each heartbeat. So you have probably watched TV and seen an EKG, a heart monitor showing that, or maybe you've gone to the hospital and seen it, and maybe you didn't know exactly what it meant. So you can see that if it's on a screen or a piece of paper, there will be a grid. So there, for the y-axis, it's going to be read in millivolts. For the x-axis, it's going to be read in seconds. So there are different waves that we'll talk about. We'll talk about the P wave, we'll talk about the QRS wave, and then we'll finalize by talking about the T wave. So changes in electrical activity will be read by deflections of a needle or deflections of the or waves that will form on a monitor that you can look at, a computer monitor. So this is different than the action potential that we read earlier in the semester or last semester. So we're not talking about action potentials. We're talking about an EKG, which is just changes in electrical activity during heartbeat. So we can take and sense these electrical changes all throughout your body. That's why they hook all these electrodes up to you. There will be a monitor and then a readout, so you can see that the changes during each heartbeat. EKGs allow us to determine if the conducting pathway, that cardiac conducting pathway, is normal or abnormal, if the heart is enlarged, if certain regions of the heart are damaged, and what the cause of chest pain might be. All right, let's look at the changes in electrical activity in the heart compared to the waves that it produces. So when that SA node sends out a signal and you begin to have depolarization of the heart cells in the atria, we get the P wave that will result from that. When the depolarization is complete, we have a little flat line after the P wave. When the ventricles begin to depolarize, we get the QRS wave. And then when depolarization of the ventricles is finished, we have a little flat line. When we have repolarization of the muscle tissue, we get the T wave. Since there's so much ventricular tissue, a repolarization is a major change in electrical activity, and we'll get a T wave that will result from that. And then after that repolarization, we get a little flat line that will occur. So this is what a normal rhythm might look like. So you can see the P wave, QRS wave, and T wave. And if you have an SA node that's non-functional, notice you don't get a P wave that is resulting from that. So very quickly, by doing an EKG, you can see if the person's SA node has been destroyed, perhaps by some kind of damage to the heart. So if the ventricle is beating in an irregular activity, we have ventricular fibrillation, and this causes an erratic EKG to be seen. So this happens during a heart attack, during electrical shock. So this is bradycardia, so a very slow rhythm, and this is tachycardia, which is a very fast rhythm. So when you go to school, you'll learn to read all different kinds of these EKGs to determine if you need to inject certain kinds of drugs or if you need to administer an electrical shock. All right, turning our gears a little bit towards heart physiology. A cardiac cycle is when both atria and ventricles contract and relax. So that would be a complete cardiac cycle. When the ventricles or atria contract, we call that systole. So atrial systole will be the atria contracting, ventricular systole will be the ventricles contracting. When either the atria or ventricles are relaxing, that's called diastole. So atrial diastole is when the atria are relaxing, and ventricular diastole are when the ventricles are relaxing. Now, the lub-dub sound that you hear during a heartbeat, so if you put your ear up or a stethoscope up to a chest and listen, you'll hear the first sound will be the lub sound, and that's the AV valves closing during ventricular contraction. That's also known as the sound S1. When the pump during ventricular diastole or relaxation, when the pulmonary and aortic valves slam shut, that's going to be called the dub sound, or S2. So movement of blood, hitting these various valves is causing that particular sound to form. So here we have atrial systole, and when atrial systole occurs, the blood is being ejected into the ventricles. During ventricular systole, blood is being ejected through the pulmonary trunk or through the aorta. But the AV valves are shutting closed. One cardiac cycle consists of the contraction and relaxation of both atria, followed by the contraction and relaxation of both ventricles. So I want to look at several different things that occur during the cardiac cycle. I want to look at the electrical events, pressure events, changes in heart sounds, volume changes in the chambers, especially the ventricle, and then mechanical ejection of blood. So the electrical events that go along with the cardiac cycle include the atrial systole or the P wave, ventricular systole or the QRS wave, and then the repolarization of the ventricles causes the T wave, and then during diastole we have a flat line. No electrical events are occurring. So pressure changes. In this particular graphic, we have millimeters of mercury. We have green is representing the left atrial pressure. Red is representing aortic pressure, so pressure in the aorta. And then blue is representing left ventricular pressure. So during atrial systole, of course, the atria are going to increase in pressure. So that green line goes up. During ventricular systole, of course, the pressure inside of the ventricle is increasing significantly. During relaxation, both the atria and ventricles, of course, their pressure inside will diminish during relaxation. During ventricular systole or contraction, the aortic pressure goes up significantly because blood is being ejected out of that vessel. Heart sounds are also correlated with the cardiac cycle. So during ventricular systole, when you have the closing of the AV valves, that's S1, sound 1, or the lub sound that you can hear. During ventricular diastole, you have S2, so the semilunar or pulmonary and aortic valves are closing, so that gives you sound number 2. During relaxation, you get also sound 3, which is the blood filling up the ventricles from the atria. And when the atria contract, you can get S4, and that's the blood being ejected out of the atria into the ventricles. You have to have a really good knowledge and really good stethoscope to hear S3 and S4. But you can go online and listen to some tutorials on heart sounds and hear what those things sound like. If you want to listen to the aortic valve, it's best that you place your stethoscope in this region of the body. If you want to listen to the pulmonary valve, this region of the body is where you would auscultate. If you want to listen to the mitral or bicuspid valve, this is the place to do that. And the tricuspid valve, this is the place to do that. So during a physical exam, you may have seen a nurse or a doctor take her stethoscope and place it in different places, different regions of the body to hear different heart sounds, to see if there's any kind of prolapse, that is the flaps going the opposite way they normally should, or stenosis, which is where there's a abnormal narrowing of the valves. So those can cause murmurs to occur, and you can hear those at different locations of the chest region. Of course, there are volume changes. The volume change in the ventricle, so volume change will increase in the ventricle during atrial systole because it's pushing blood into the ventricle. Of course, when the ventricle contracts, the volume goes down because the blood's being ejected out of the heart. During relaxation, as the blood trickles from the atria to the ventricles, ventricular volume will increase. And of course, there are mechanical ejections of blood. So the atrial contraction or atrial systole will eject blood into the ventricular chambers. When the ventricle systole occurs, the AV valves will shut and blood will be ejected through the pulmonary trunk or through the aorta. During relaxation, we don't have any major events that are occurring, except at the end you might have atrial refilling just because of gravity. Atrial blood will be dripping into the ventricle, and that will be blood movement into the ventricle. And you can go online or look in your textbook and see that there are charts that have everything that we just talked about, but it's all in one diagram. Okay, so cardiac output is the volume of blood ejected from the left or right ventricle into the aorta or pulmonary trunk each minute. This is a pretty important measurement to know how the heart is working. The stroke volume, on the other hand, is the amount of blood pumped out of the ventricle in one beat. So we can measure that volume of blood in one beat, one squeeze into the heart of the ventricle, how much blood's being ejected out of that. There is a relationship between cardiac output and stroke volume and heart rate. So cardiac output in milliliters per minute equals stroke volume, the amount of blood being ejected out of the ventricle, which is a milliliter per beat, times how many times the heart beats per minute. So that's how the cardiac output is related to stroke volume and heart rate. So there are factors that affect heart rate. So the autonomic nervous system in regards to the parasympathetic nervous system lowers the heart rate. Sympathetic nervous system will speed it up. There are hormones such as epinephrine, norepinephrine, and thyroid hormones. Generally, these will speed the heart up. Ions such as sodium, potassium, and calcium will also regulate the heart rate as well. Age, so heart rate is high in infants and it declines with age. Gender, females typically have a higher heart rate than males. So people that do endurance exercises typically have a decreased heart rate at rest because they've exercised their heart so much they are really efficient at sending blood through the body. Heart rate increases in higher temperatures and decreases in lower temperatures. This is just showing the vagus nerve being the division of the parasympathetic nervous system that will innervate the heart and cause it to slow down. And the sympathetic nervous system uses spinal nerves to innervate the heart and cause it to speed up. So there are sensors that are always monitoring what's going on in the bloodstream and in other places of the body. If something has to be adjusted, there is that information is interpreted by the cardiovascular center in the medulla. That will actually take and activate the sympathetic nervous system if something needs to be increased in terms of heart rate or contractility. If it needs to be decreased, then the vagus nerve will be used to slow that down. That's the division of the parasympathetic nervous system that will slow it down. There are factors that affect cardiac output. So cardiac output can be influenced by the changes in stroke volume and changes in heart rate. So we can change the heart rate by looking at gender, health, or temperature outside the body, various chemicals that are that the heart's being exposed to, and influences of the nervous system such as the parasympathetic or sympathetic nervous stimulation. Stroke volume can also be influenced by things such as the contractility of the heart, how forcefully the heart is contracting. How much blood is there left after a contraction? So the preload volume is going to influence how much volume, total volume, will be ejected in a stroke volume. And so resistance by, say, the arterial pressure outside of the heart, this can influence significantly the amount of blood that can be ejected out. If there's a lot of resistance, very little blood can be ejected against that resistance. If there's very little resistance, then more blood can be ejected out. So that stroke volume will be and cardiac heart rate will influence how much cardiac output will occur. And then let me make a little plug for regular aerobic exercise. Aerobic exercise is really important because it increases your cardiac output and that strengthens your heart muscle tissue. It'll actually enlarge the heart. Your muscle tissue can enlarge based on the physical activity that you do. Because of regular aerobic exercise, we can increase the HDLs, which are the good cholesterol, which will diminish bad cholesterol. We can decrease triglycerides, which are considered to be unhealthy at very high rates. We can improve lung function. We can decrease blood pressure at rest, and we can assist in weight control. So all of these things are really important for us to think about, especially while we're young and healthy, to do these things so that we can have a nice healthy weight and body. So that completes this particular lecture on the heart. In the next lecture, we're going to tackle blood vessels. And so until I see you then, I wish you a good morning or a good day or a good night. And I will see you next time.